Hello, and welcome to the Chest Journal Podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Gretchen Winter.
On behalf of Chest, I would like to welcome you to this Chest Journal podcast. My name is Dr. Gretchen Winter, and I am your Chest podcast moderator. Thank you all for joining us today for a discussion with Dr. Shota Yamamoto, Dr. Takayuki Niitsu, and Dr. Kenneth Olivier. Drs. Yamamoto and Niitsu and their colleagues wrote an article in the Chest Journal, Efficacy of Anti-Inflammatory Therapies for Adults with Non-Cystic Fibrosis Bronchiectasis, a systematic review and network meta-analysis. Now, Dr. Yamamoto is a physician scientist and a board-certified pulmonologist and internist who developed advanced expertise in evidence synthesis through his work as a guideline committee member for the Japanese Respiratory Society clinical practice guidelines, including those for acute respiratory distress syndrome, pulmonary hypertension associated with respiratory diseases, and the management of cough and sputum, along with a strong command of systematic review and meta-analysis methodology. He was awarded a Japan Society for the Promotion of Science Overseas Research Fellowship and completed postdoctoral research training at the Lynn Schnapp Laboratory at the University of Wisconsin and continues to participate in the lab's research program remotely. His research spans molecular biology to clinical investigation with a focus on acute lung injury and the biology of inflammation and pulmonary fibrosis. Dr. Niitsu is a board-certified pulmonologist at Osaka University and Osaka General Medical Center in Osaka, Japan. He earned his PhD through clinical research and spatial transcriptomics using patient samples with a focus on interstitial lung diseases and progressive pulmonary fibrosis. He is also actively involved in real-world clinical research, including bronchiectasis epidemiology and antifibrotic therapy outcomes, and he serves as a project PI on multiple competitive research grants. His current interests include mechanism-driven lung disease research and translating evidence into practice, particularly in ILD and bronchiectasis. Dr. Olivier is also joining us to discuss the applicability of this study to our population in the USA. Now, Dr. Olivier is the Michael E. Hatcher Distinguished Professor of Medicine, Microbiology, and Immunology at the University of North Carolina School of Medicine. He's the Research Director of the UNC Bronchiectasis NTM Care and Research Center and the Co-Director of the PCD Foundation Network for Clinical Trials Leadership Center. Dr. Olivier was a site investigator and project lead for the NIH-funded Genetic Disorders of Mucociliary Clearance for almost 20 years, and is the current co-lead of the NHLBI-funded Rare Bronchiectatic Diseases Consortium. His research focuses on host susceptibility, pathogenesis, and population characteristics of bronchiectasis and chronic airway infection, such as the nontuberculosis mycobacteria, and he has been actively engaged in preclinical and clinical therapeutics development in these areas. He has authored and co-authored over 200 peer-reviewed research papers, review articles, and book chapters pertaining to these topics. So we are so excited to have you all. Thank you so much for joining us today.
Yeah, thank you. Thank you for having me. I'm very happy to join this interview.
Thank you for inviting me today, and I'm really excited to talk with you.
And it's my pleasure to join this podcast today. Thank you for the invitation and opportunity.
Absolutely. So let's jump right in. You all looked at the safety and efficacy of anti-inflammatory therapies for bronchiectasis. So I'm curious what prompted you guys to ask this specific topic. Why are you researching this?
Thank you very much, Dr. Winter. So 2 years ago, I ran a 1,000 patient epidemiology study on bronchiectasis in Japan with Dr. Kiyoharu Fukushima, Dr. Kazuki Hashimoto, and Dr. Kozo Morimoto. In the study, I found that almost half of patients developed NTM during follow-up. But in Japan, even through clinician watch for NTM, macrolides were used very often, even without exacerbations. So I started to ask a simple question. Are we using anti-inflammatory treatment in the best way? Also, during exacerbations, care was mostly supportive. This included giving antibiotics based on the detected bacteria. So I felt that bronchiectasis management was still not well organized. To step back for a moment, bronchiectasis is often explained by vicious vortex, infection, inflammation, and mucus keep making each other worse. And in recent years, we have learned that neutrophil-driven inflammation is closely linked to disease progression. Because of that, new treatments have appeared. Aspen trial result highlighted DPP1 inhibition as a new approach to targeting neutrophil. Therefore, we focus on the drug in terms of anti-inflammation. However, we still lack a clear, comprehensive comparison across anti-inflammatory options. So to answer this gap, we performed a systematic review and network meta-analysis to compare efficacy and safety across therapy in bronchiectasis.
Actually, my motivation is a little bit different from Takayuki's. Working as a physician, I've often felt how limited, solid, and reliable evidence can be in daily practice. And you would notice it when a new type of drug shows up. Suddenly, everyone's learning on the fly. Actually, randomized control trials are still the gold standard, but they are not perfect. A big issue is that once you try to compare several drugs, you end up needing a huge number of patients and big funding. And if you want results that hold up across different countries, it usually takes more than just regulatory approval. You also need real understanding and cooperating from industry. So that's where meta-analysis can help to address. When it's done carefully with clear and transparent protocols, it can put the existing evidence together in a way that's truly useful for clinical decision making. So that's why I like this kind of work, and with bronchiectasis management moving into a new phase, I wanted to offer findings that are as fair as much possible.
What did we know from the literature before this about the use of anti-inflammatory therapies in bronchiectasis? Dr. Yamamoto?
Okay, so I'm going to talk about the recent paradigm shift and a brief history of anti-inflammatory treatment. In bronchiectasis, research focus is shifting from the cause to disease activity. Actually, I know the cause remains vital because some patients require specific examinations and treatment for underlying disease. For example, alpha-1 antitrypsin deficiency, primary ciliary dyskinesia, sometimes autoimmune disease, etc. However, in addition to conditioning the underlying disease, we need to evaluate the disease by its inflammatory activity and the inflammatory phenotype in actual clinical practice. Looking at the biology, bronchiectasis is explained by a visual vortex models. This model is component of chronic infection, prolonged inflammation, mainly driven by neutrophils and T cells, and airway dysfunction, that's including the epithelial dysfunction, hyperproductive mucus, and ciliary dysfunctions. Those feeds on each other, and then this cycle results in lung destruction and bronchiectasis. In particular, we've learned that neutrophil-driven inflammation is directly linked to disease progression. Even today, it's sometimes difficult to prevent exacerbation in patients with advanced or end-stage bronchiectasis. Clinical trials of anti-inflammatory treatment in non-cystic bronchiectasis has prolonged in three major waves. The first wave is inhaled corticosteroid, which are borrowed from experiments with asthma and COPD. But actually, they demonstrated a very neutral effect on reducing exacerbation. Moreover, some observational studies report that prolonged usage of ICS is associated with increased risk of bacterial pneumonia, non-tuberculous mycobacterial infection, and diabetes. That's why current guidelines do not recommend usage ICS for every patient with bronchiectasis in daily routine work. The guideline recommends it only in cases considered as eosinophilic inflammation, for instance, bronchial asthma, ABPA, and eosinophilic bronchitis, etc. Second wave was long-term macrolide antibiotics. Today, this agent became more and more important to manage the bronchiectasis. From 2012, 3 key trials, EMBASE, BREATH, and BAT trials showed up in a row. They demonstrated that azithromycin or erythromycin reduced exacerbations by around half. A Cochrane review of long-term macrolide also confirmed a similar effect in patients with bronchiectasis, including children and adults. Based on this evidence, the ERS and the BTS guidelines were updated. The latest guidelines from ERS also recommends long-term macrolide use for adults at high risk of future exacerbations. However, in case of chronic infection of Pseudomonas aeruginosa, the guideline recommend trying using inhaled anti-pseudomonal antibiotics before oral administration of macrolides. Between the second and third waves, physicians evaluated the other types of anti-inflammatory drugs to control long-term airway inflammation, such as CXCL2 agonists, PDE4 inhibitors, and statins. However, these agents did not show a clear benefit in reducing exacerbations. Attention moved to neutrophilic inflammation. As you know, the third wave is DPP1 inhibitors. Strong neutrophil enzymes and neutrophil extracellular traps can damage and destroy the airway structure. DPP1, also known as cathepsin C, is an enzyme that activates neutrophil serine protease. That's including the neutrophil elastase proteinase 3, and cathepsin Z during white blood cell maturation. Inhibition DPP1 prevents these destructive enzymes from activating, reducing inflammation in chronic lung disease. In the Willow trials, phase 2 randomized control trials in 2020 and the Aspen trials in 2025, the oral DPP1 inhibitor brensocatib delayed further exacerbation and reduced total and severe exacerbation without additional safety concerns. Despite this progress, evidence for anti-inflammatory drug groups as long-term macrolides remains limited, and head-to-head trials are very rare. This means clinicians still lack a comprehensive framework for selecting actual treatment. To fill the gap, we performed a systematic review and network meta-analysis of anti-inflammatory treatment for bronchiectasis.
Well, can you please give us a brief overview of your study design?
Sure. So I'll introduce the basis of systematic review and meta-analysis, and then a little bit goes deeper into our studies. A systematic review is a structured way to identify all relevant studies by searching at least 2 databases using predefined strategies. Meta-analysis is statistical steps that comes after that. It combines the evidence we collected in the systematic review and produce a new pooled estimate. When there is just only one intervention of interest, we typically use what is called pairwise meta-analysis. In this approach, we put trials that compare the intervention against a common comparator, mainly placebo, to estimate how much benefits the intervention provides relative to placebo. In our studies, we went a step forward and used a more advanced approach called network meta-analysis. Network meta-analysis is designed for situations where we want to compare multiple interventions at the same time. Conceptually, each treatment class like inhaled corticosteroid, macrolides, and DPP1 inhibitors become a node in a network. Trials that directly compare two options are connected by lines. Then, within that network, we estimate the relative effects across all interventions, combined both direct evidence from head-to-head trials and indirect evidence through a shared comparator. Compared with the standard pairwise meta-analysis, network meta-analysis requires additional checking point. In particular, we need to assess the transibility and inconsistency. That said, this approach matched our research question very well, and when it's applied very carefully, it can be very useful for clinical decision making. And what counts as an eligible trial depends on the research question, and we structure the question using PICO format. For this study, we define the PICO as follows. P means populations was adults aged 18 or older with bronchiectasis diagnosed with chest CT scans. And I means interventions was any anti-inflammatory treatment that has been studied and published to date. C or comparison was placebo or different type of anti-inflammatory therapies. And finally, O is outcomes that includes exacerbations, exercise tolerance, lung function, and adverse events, including mortality. Sometimes reviews including observational studies or non-randomized designs. In our review, we restricted include to randomized control trials only because we did that to reduce bias and unknown confounding as much as possible so that the estimated treatment effect would be more credible. A key feature of systematic review and meta-analysis is that they follow transparent protocol and standardized reporting formats. Our protocol was prospectively registered in Prospero, and our full methodology, including the search strategies and the study section criteria, is provided in the supplementary appendix in the paper. We conducted the review in accordance with the Cochrane Handbook, and we assessed the trial level risk of bias using the Cochrane risk of bias tool, and we evaluated the overall certainty of the evidence using the GRADE framework. Finally, we reported the review following Prisma. It's to keep the process as fair as reproducible as possible. So in a network meta-analysis, we do not just present the size of the effect, we also present how confident we can be in that effect size based on the quality of the included trials. In GRADE, certainty is rated across 4 levels: high, moderate, low, and very low. In practice, low and very low certainty usually means the estimate is not so reliable and the true effect may be different. We also ran several sensitivity analyses to confirm that our main estimates did not change substantially under different assumptions. And to make the result more clinically usage, we conducted two subgroup analyses. First, we compared trials enrolling patients who were on long-term macrolides at baseline versus those who were not. And second one is within the macrolide studies, we performed an additional analysis of variation within that drug class.
So you guys specifically looked at outcomes with DPP-1 inhibitors like bronchiectasis, inhaled corticosteroids, and macrolides. So what did you find in terms of exacerbation outcomes with these therapies? Dr. Niitsu?
Yes, thank you very much. Let me explain the main result. Compared with placebo, two treatment clearly reduced the exacerbations. First, long-term macrolides, they reduce exacerbation to about half. Second, DPP-1 inhibitors, they reduce exacerbation by around 1/4. In contrast, ICS plus LABA didn't show a consistent reduction in exacerbation. For severe exacerbation, DPP-1 inhibitors show a clear reduction in severe exacerbations. Macrolides also look better, but there were fewer trials and fewer events, so the conclusion is not fully clear. Also, the definition of severe exacerbation was not common in all the trial. It became more standard after the Willow trial. In summary, DPP-1 inhibitors and macrolides showed similar good result. They extended the time to the first exacerbation. They also reduced the number of people who had at least one exacerbation. That's all.
Excellent. Well, what about the efficacy outcomes of these therapies?
Okay, thank you. So beyond just looking at the exacerbation, we also look at how these treatments affect daily lives and lung strengths of patients. First, when it comes to quality of life, we used a standard questionnaire called the SGRQ. None of the medicine we studied showed a measure improvements, and the result for all the drugs were not clearly better than placebo. The same was true for physical activity. As for function tests, the improvements were modest at best across almost all the therapy we analyzed. In fact, some treatments like statin even pointed toward a slight decline in lung function rather than an improvement. One unique finding was about airway inflammation. Only the DPP-1 inhibitors shows a consistent ability to reduce a specific marker of inflammation called neutrophil elastase in the patient's lung. Other drugs, like statin, didn't change this marker at all. So while some of these drugs are very helpful for preventing exacerbation, our analysis shows they don't necessarily make patients feel significantly better or improve their exercise capacity in a major way. Thank you.
And what did you find regarding the safety of these different therapies?
Thank you very much, Dr. Winter. Generally speaking, we found that most of these anti-inflammatory treatments were quite safe and well tolerated. When we look at how often patients had to stop their treatment or experience general side effect, the rates were trivial or very small for almost all the drug we studied. In fact, for most therapies, the side effects were very comparable to what patients experience on the placebo. However, PDE4 inhibitor was the only group that showed a higher rate of side effect compared to the placebo. So the main message of the result is this: for overall exacerbation, macrolide and DPP-1 inhibitor reduce exacerbation, and they look clinically important. For severe exacerbations, DPP-1 inhibitor also reduces them.
Can you please share some of the limitations of your study?
Okay, thank you for the question, Dr. Winter. So first, a major limitation is that many of trials we analyzed allowed patients to continue their concomitant background treatment, such as macrolide or inhaled corticosteroids. Because only a few trials provided data breaking down these results, it was difficult for us to perform formal assessment of drug interactions, provide a pure head-to-head comparison between different therapies. Second, we have to talk about NTM. In 24 of the 31 trials we reviewed, patients with NTM were explicitly excluded. And this means we still don't know enough about how these anti-inflammatory drugs, especially the new DPP1 inhibitors, perform in patients with active NTM infections. Third, there was significant inconsistency in how trial defined an exacerbation. For instance, our trial often didn't have a standard definition for a severe event, and many relied on whether or not the doctor decided to prescribe antibiotics. This variability makes it harder to draw definitive conclusions, particularly regarding severe exacerbations. Fourth, we didn't analyze results separately for each individual DPP1 inhibitor. Fifth, many patients were already on standard of care at baseline, so background treatment could affect the result. Also, we were limited by a lack of detailed biological data, information regarding specific inflammatory endotype, like eosinophilic inflammation, or the patient's airway microbiota was often absent or too limited to allow for deeper analysis. I stop there.
Now, what unique findings does your study add to the literature around the treatment of bronchiectasis? What do we know now that we didn't know before this meta-analysis?
Thank you for the question, Dr. Winter. The most unique aspect of our study is that it is a network meta-analysis to incorporate the new DPP1 inhibitors. This allowed us to provide a comprehensive comparison of all the major anti-inflammatory therapies currently available for bronchiectasis. What we know now that we didn't before is that DPP1 inhibitors work effectively even for patients who were already taking long-term macrolides. Previously, it was unclear if adding a second anti-inflammatory drug would provide any additional benefit, but our findings suggest these treatments may play complementary roles. In the Japanese subgroup analysis of the ASPEN trial, about 75% of Japanese patients were taking macrolides. Even in this setting, the drugs still showed a strong reduction in exacerbations, which is consistent with our overall findings. Therefore, we believe that DPP1 inhibitors have reliable efficacy and acceptable safety profile, and they can be recommended as a treatment option. We also found a very specific biological difference. DPP1 inhibitor was the only therapy that consistently reduced the neutrophil restade, a key marker of tissue damaging inflammation in the airways, as drugs we tested, like statin, didn't show this effect at all. Finally, our study adds clarity to the hierarchy of treatment by showing that while azithromycin is the most effective macrolide for preventing exacerbation, other common treatment like inhaled steroid and statin don't show a consistent benefit for these patients. This helps clinicians move away from simply borrowing treatment from asthma or COPD and toward bronchiectasis specific mechanism-based care. I stop there.
So, Dr. Olivier, I'd like to ask you to weigh in on the applicability of these results to the USA. So first, bronchositip has a listed price in the US, but what is the actual cost or the access situation in practice now?
Well, as you may know, the first of these DPP1 inhibitors, brensocatib, was approved for use in the U.S. by the FDA in mid-August of last year, and the cost often quoted is $88,000 per year. That sounds very high. However, our experience has been that through a combination of private insurance coverage, Medicare coverage, and patient support programs, almost all of our patients have been approved with minimal to no copays.
Now, the next question I have is, how do we know which one of us is pronouncing this correctly?
Well, I was told that cat is in the middle of it, so that you can take the rest from it.
Okay, well, that's good to know. See, these are the things they don't teach in medical school. So, moving on, regarding the use of macrolides, the perception of adverse events may differ between the US and Japan. So what is your impression of the use of long-term macrolides for these patients in the US? And additionally, how do the concerns for NTM infection and then long-term macrolide use and resistance patterns factor into the decision on chronic macrolide use here?
Yeah, thanks for that question. I think most pulmonologists in the U.S. Think of azithromycin when we consider whether or not to use macrolides in bronchiectasis. This is problematic, as you know, given the appropriate concern for NTM and the potential for precipitating acquired macrolide resistance from monotherapy with azithromycin. The prevalence of NTM in the U.S. And Japan are equally high. And until recently, I had not considered the use of erythromycin, which is commonly used in Japan, as far as I understand, and for which there is ample data to support its use without the concern for precipitating macrolide resistance in NTM patients. I've had the perception in the past that the gastrointestinal side effects associated with erythromycin were more significant than with azithromycin. But I think that with better understanding of practices in Japan, I've started using erythromycin more in my practice when considering macrolides as an anti-inflammatory.
Now, what do you see as future steps for this research? Dr. Niitsu?
Yeah, thank you, Dr. Winter. That's a very important question. While our study provides a much-needed comparison, it is also highlights exactly where the map of bronchiectasis research still has some blank spaces. First, we need to transition from clinical trial to real-world evidence. We need to test our findings using large-scale registry to see how the drug perform in the broader, more diverse patient population we see in our clinics every day. This is where we need to focus on specific clinical themes that we still don't fully understand. For example, the best way to add on new therapy for patients already taking macrolides, the impact of switching a patient from macrolide to a DPP1 inhibitor, or even whether an initial combination of both therapies from the start provides superior protection. Second, we need to focus on personalized medicine. We need to identify which drug is best for which specific patient. For instance, we need to pinpoint endotypes like the eosinophilic endotype, where treatments like inhaled corticosteroid might actually be effective, even though they didn't show a benefit for the general population in our study. Third, we have to look at the long-term strategy and timing. We still don't know the best time to start these therapies. Should we be treating early stage patients to prevent damage before it becomes severe? We also need data on the optimal duration of treatment and whether these new drugs, like DPP1 inhibitors, provide a sustained protective effect against lung tissue injury over several years. Finally, we need to understand the combination care. We need to study how the anti-inflammatory drugs interact with other pillars of care, such as airway clearance technique and inhaled antibiotics. Also, since our study largely excluded them, we urgently needed to know the impact of these new therapies on patients with active NTM infection. Ultimately, the goal is to move toward personalized and mechanism-based care, specifically for bronchiectasis. That's what I do.
So for our last question here, if you could give our listeners a closing thought on what you've learned from this research and moving forward, what do you want them to take away from this discussion? Dr. Niitsu?
Oh, yes, sure. This research has three main messages. First, when we compare anti-inflammatory drugs for bronchiectasis across randomized trial, two options have the clearest evidence to reduce exacerbations, long-term macrolides and DPP1 inhibitors. Second, DPP1 inhibitors may also reduce severe exacerbation, and even in patients who are already using macrolides, the effect of a DPP1 inhibitor was in the same direction. Third, for other anti-inflammatory drugs like inhaled steroids, the current evidence is not strong enough to show a consistent reduction in exacerbation. So in practice, we should first optimize infection control and airway clearance, Then for patients with frequent exacerbation, we can consider these two options. Next, we still need clear answer about when to start and which patient benefit the most. Thank you.
Dr. Yamamoto?
So one important point is that systematic reviews and meta-analysis based on aggregate data follows very well-established, highly transparent methods. That transparency makes them reproducible. That means if researchers around the world follow the same protocols, they should arrive at essentially the same conclusions. At the same time, when we applied meta-analysis findings to real-world clinical care, we often need to interpret them through the lens of the local healthcare context. Healthcare context includes a lot: access to medications, potential differences in treatment response or adverse events across patient populations, and also the structures of insurance and sometimes co-payment systems among other factors. So my hope is that before applying these findings to the patient in front of you, you pause for a moment and make a careful, thoughtful judgment about how well the evidence fits your setting and your patients. Thanks.
Dr. Olivier?
I certainly agree with the prior comments. I think the evidence for azithromycin has been re-emphasized in this with comparable results affecting reduction in acute exacerbations relative to placebo for both azithromycin and the DPP1 inhibitor. And I think when seeing patients, cost needs to be taken into effect. And careful looking for non-tuberculous mycobacteria if azithromycin use is considered. But things being relatively equal, a trial of azithromycin first seems appropriate. I think the other thing that is important to emphasize from this work is the additive effect of brensocatib on top of azithromycin for those patients who may either not respond to azithromycin alone or have difficulty taking azithromycin. The use of brensocatib in those patients seems very reasonable and has been used safely in those patients as well.
Well, a big thank you to Drs. Yamamoto, Niitsu, and Olivier for a pronunciation lesson for me and a great conversation on such an interesting topic. And as always, a big thank you to our CHEST community for joining us. I'm Gretchen Winter, and this is a CHEST podcast. Until next time.